Anaesthesiology Respiratory Anatomy, Q&A. Welcome to today's podcast on respiratory anatomy for residents in anesthesiology. Today, we will take you through 100 essential questions, each presented and answered clearly for your learning. Pause the video after each question to attempt answer. Let's begin. Upper airway anatomy question. What are the boundaries of the upper airway? Answer. The upper airway extends from the nares or nasal openings and the lips to the larynx at the level of the vocal cords. Question. Name the three main parts of the pharynx. Answer. The three main parts are the nasopharynx, oropharynx, and laryngopharynx, which is also known as the hypopharynx. Question. What is the vallecula and why is it important? Answer. The vallecula is a depression between the base of the tongue and the epiglottis. It is an important landmark during direct laryngoscopy because the tip of the Macintosh blade is designed to rest here to indirectly lift the epiglottis and visualize the glottis. Question. What nerve provides sensory innervation to the nasopharynx? Answer. The maxillary division, also known as V2, of the trigeminal nerve via the sphenopalatine ganglion. Question. What nerve provides sensory innervation to the oropharynx, including the posterior tongue? Answer. The glossopharyngeal nerve, which is the ninth cranial nerve. Question. What is the clinical significance of the lingual tonsils? Answer. Hypertrophy of the lingual tonsils can obscure airway visualization, contribute to obstructive sleep apnea, and are often not assessed during a standard airway examination. Question. What is the piriform fossa, also called the piriform sinus, and why is it important? Answer. These are recesses on either side of the laryngeal inlet and are common sites where foreign bodies such as a misplaced bougie or stylet can become lodged. The internal branch of the superior laryngeal nerve runs deep to the mucosa here. Question. What is the narrowest part of the adult airway? Answer. The glottis, which is at the level of the vocal cords. Question. What is the narrowest part of the pediatric airway and why does it matter? Answer. In children younger than 8 years, it is the cricoid cartilage, a complete ring. An endotracheal tube that passes easily through the vocal cords may still be too tight at this level, risking mucosal ischemia and possible post-extubation stridor or subglottic stenosis. Question. Describe the sensory innervation of the larynx. Answer. Sensation above the vocal cords is supplied by the internal branch of the superior laryngeal nerve, a branch of the vagus nerve. Below the vocal cords, sensation is supplied by the recurrent laryngeal nerve, also a branch of the vagus nerve. Larynx and vocal cords question. What are the only paired laryngeal cartilages? Answer. The arytenoid cartilages. Question. What is the function of the cricothyroid muscle? Answer. The cricothyroid muscle is the only tensor of the vocal cords, lengthening and tightening them. It is innervated by the external branch of the superior laryngeal nerve. Question. What muscles abduct the vocal cords? Answer. The posterior cricoridinoid muscles. Question. What muscles adduct the vocal cords? Answer. The lateral cricoridinoid, transverse arytenoid, also called interarytenoid, and therarytenoid muscles. Question. What nerve provides motor innervation to all the intrinsic muscles of the larynx except one? Answer. The recurrent laryngeal nerve supplies all intrinsic laryngeal muscles except the cricothyroid muscle. Question. What is the clinical consequence of a unilateral recurrent laryngeal nerve injury? Answer. The affected vocal cord assumes a paramedian position, often resulting in hoarseness, but the airway usually remains patent. Question. What is the clinical consequence of a bilateral recurrent laryngeal nerve injury? Answer. Both vocal cords assume a paramedian position, which can cause stridor and acute airway obstruction, possibly necessitating emergency tracheostomy. Question. Where is the cricothyroid membrane located and why is it important? Answer. It is located between the thyroid cartilage above and the cricoid cartilage below. It is the preferred site for emergency surgical airway access because it is superficial, avascular, and easy to palpate. Question. What important structure lies just lateral to the thyroid cartilage? Answer. The carotid artery. Question. What is the epiglottis made of? Answer. Elastic cartilage, unlike the hyaline cartilage of the thyroid and cricoid. Tracheobronchial tree question. At what vertebral level does the trachea begin and end? Answer. The trachea begins at cervical vertebra 6, at the level of the cricoid cartilage, and ends at the carina, approximately at thoracic vertebra 4 or 5, which corresponds to the angle of Lewis. Question. How many cartilaginous rings support the trachea? Answer. 16 to 20 C-shaped rings. Question. What is the structure of the posterior tracheal wall? Answer. It is membranous, not supported by cartilage, and contains the trachealis muscle. Question. At the carina, which mainstem bronchus is more vertical, wider, and shorter? Answer. The right mainstem bronchus. Question. Why is right mainstem intubation more common? Answer. Because the right mainstem bronchus is more vertical and wider, an endotracheal tube advanced too far will naturally enter it. Question. What structure arches over the right mainstem bronchus? Answer. The azygous vein. Question. What structure passes anterior to the left mainstem bronchus? Answer. The left pulmonary artery, creating the aorta pulmonary window on imaging. Question. How many lobar bronchi are on the right and on the left? Answer. Right lung has 3 lobar bronchi, upper, middle, and lower. Left lung has 2, upper and lower, with the upper lobe having a lingular division. Question. What is the first branch of the right mainstem bronchus? Answer. The right upper lobe bronchus, which is very close to the carina and can be easily obstructed by an endotracheal tube or bronchial blocker. Question. Which bronchus is the most likely site for foreign body aspiration and why? Answer. The right lower lobe bronchus, due to its more vertical orientation. Lungs and pleura. Question. How many lobes does each lung have? Answer. The right lung has 3 lobes, upper, middle, and lower. The left lung has 2 lobes, upper and lower. Question. What are the fissures of the right lung? Answer. The oblique fissure and the horizontal fissure. Question. What is the fissure of the left lung? Answer. The oblique fissure. Question. What is the hilum of the lung? Answer. It is the medial surface where structures such as the bronchus, pulmonary arteries and veins, nerves, and lymphatics enter and exit the lung. Question. What is the order of structures at the hilum from anterior to posterior? Answer. Veins, artery, bronchus. On the left, the pulmonary artery is the most superior structure. Question. What is the difference between a bronchopulmonary segment and a lobe? Answer. A lobe is divided into segments, each supplied by its own segmental bronchus and artery. The segment is the functional surgical unit of the lung. Question. How many bronchopulmonary segments are in each lung? Answer. There are 10 in the right lung and 8 to 10 in the left lung. Question. What is the pleura? Answer. A serous membrane that covers the lungs, called visceral pleura, and lines the thoracic cavity, called parietal pleura. Question. What is the innervation of the visceral pleura? Answer. The autonomic nervous system, mainly the vagus nerve. It is insensitive to pain. Question. What is the innervation of the parietal pleura? Answer. The intercostal nerves and the phrenic nerve. The parietal pleura is sensitive to pain, pressure, and temperature. Diaphragm and muscles of respiration. Question. What is the primary muscle of inspiration? Answer. The diaphragm. Question. What nerves innervate the diaphragm? Answer. The phrenic nerves, originating from cervical vertebrae 3, 4, and 5. Question. What are the accessory muscles of inspiration? Answer. The sternocleidomastoid, scalene muscles, and external intercostals. Question. What are the muscles of active expiration? Answer. The internal intercostals and the abdominal muscles, including the rectus abdominis, external and internal obliques, and transversus abdominis. Question. What are the openings in the diaphragm and what passes through them? Answer. At vertebra 8, the caval hiatus for the inferior vena cava and right phrenic nerve. At vertebra 10, the esophageal hiatus for the esophagus and vagus nerves. At vertebra 12, the aortic hiatus for the aorta, thoracic duct, and azygous vein. Question. Why can hiccups be a problem postoperatively? Answer. Hiccups involve involuntary diaphragmatic contractions against a closed glottis, causing pain at surgical sites and disrupting ventilation and oxygenation. Innervation and reflexes. Question. What is the afferent and efferent limb of the cough reflex? Answer. The afferent limb consists of irritant receptors in the airway mucosa via the vagus nerve. The efferent limb involves the phrenic and spinal nerves to the diaphragm and abdominal muscles, and the recurrent laryngeal nerves to the larynx. Question. What is the afferent and efferent limb of the hiccup, also called singultus reflex? Answer. The afferent limb consists of phrenic and vagus nerves. The central part is in the brainstem, and the efferent limbs are the phrenic nerve to the diaphragm and the recurrent laryngeal nerve to the glottis. Question. What nerve is blocked during a superior laryngeal nerve block? Answer. The internal branch of the superior laryngeal nerve, providing analgesia to the supraglottic region. Question. What is the risk of a bilateral deep cervical plexus block? Answer. Bilateral phrenic nerve palsy, leading to diaphragmatic paralysis and respiratory failure. Blood supply question. What is the blood supply to the lungs? Answer. The lungs have dual supply. The pulmonary arteries carry deoxygenated blood for gas exchange, and the bronchial arteries supply oxygenated blood to the lung tissue itself. Question. What is an important anatomical variant to consider during pulmonary artery catheterization? Answer. The right pulmonary artery passes posterior to the ascending aorta and superior vena cava. A catheter can potentially pass into the right pulmonary artery. Question. What is the clinical significance of the bronchial circulation? Answer. It can be a source of significant hemorrhage and provides collateral blood supply, explaining why pulmonary embolism does not usually cause lung infarction in healthy people. Question. What is the venous drainage of the lungs? Answer. Pulmonary veins return oxygenated blood from alveoli to the left atrium. Bronchial veins drain a small portion of the blood supplied by the bronchial arteries. Lymphatics question. Where does lymph from the lungs drain? Answer. Into tracheobronchial lymph nodes around the carina and main bronchi, then into the right and left bronchomediastinal trunks, which drain into the subclavian veins. Question. Why is the right supraclavicular node sometimes called the sentinel node? Answer. It is often the first palpable node involved in metastases from intrathoracic malignancies such as lung cancer. Surface anatomy and landmarks question. What is the sternal angle, also called the angle of Lewis? Answer. The palpable angulation where the manubrium meets the body of the sternum. Question. What is the clinical significance of the angle of Lewis? Answer. It corresponds to the fourth thoracic vertebral level, the level of the carina, the aortic arch, and the bifurcation of the trachea. Question. At which rib midclavicular line does the diaphragm lie? Answer. Approximately the fifth rib. Question. At which rib midaxillary line does the diaphragm lie? Answer. Approximately the eighth rib. Question. At which rib paravertebrally does the diaphragm lie? Answer. Approximately between the 10th and 12th thoracic vertebrae. Question. Where do you percuss for liver dullness? Answer. From the 5th intercostal space in the right midclavicular line down to the right costal margin. Question. Where is the best place to listen for bronchial breath sounds? Answer. Over the manubrium. Developmental anatomy question. From which germ layer does the respiratory system develop? Answer. The epithelial lining develops from the endoderm, while the cartilage, muscle, and connective tissue develop from the mesoderm. Question. When does surfactant production begin? Answer. Around 20 to 24 weeks gestation, with significant production occurring around 32 to 34 weeks. Question. What is the clinical implication of the pediatric larynx being more anterior? Answer. It makes visualization with a standard laryngoscopic technique more difficult. A straight blade and paraglossal technique are often more effective. Clinical applications in anesthesiology question. Why must an anesthesiologist be cautious with nasotracheal intubation or nasogastric tube placement? Answer. There is a risk of bleeding from the highly vascular Kieselbach's plexus on the anterior nasal septum. Question. What is the risk of using excessive cuff pressure in an endotracheal tube or laryngeal mask airway? Answer. Excessive pressure can cause mucosal ischemia, leading to sore throat, vocal cord granulomas, tracheal stenosis, or tracheoesophageal fistula in endotracheal tubes and various nerve palsies in laryngeal mask airways. Question. Why is the left double lumen tube preferred over the right? Answer. The right upper lobe bronchus originates very close to the carina, making a right-sided tube harder to position. The left mainstem bronchus is longer, allowing more margin for error. Question. During one lung ventilation, where does shunt flow occur? Answer. Through the non-ventilated but still perfused lung, which is the primary cause of hypoxemia during one lung ventilation. Question. What is the path of a chest tube for a pneumothorax? Answer. The tube is placed in the safe triangle, anterior to the mid-axillary line, lateral to pectoralis major, and above the nipple level, usually in the 4th or 5th intercostal space. Question. What nerve is at risk during a thoracocentesis or chest tube insertion? Answer. The intercostal nerve, which runs in the neurovascular bundle along the inferior aspect of each rib. The procedure should be performed at the superior border of the rib below. Question. What is the anatomical basis for post-intubation hoarseness? Answer. It is often due to edema or trauma to the vocal cords or the recurrent laryngeal nerve. Question. Why is the right lung more susceptible to atelectasis during mechanical ventilation? Answer. The right mainstem bronchus is more vertical, making it easier for secretions to collect and cause obstruction. Question: what anatomical factors contribute to obstructive sleep apnea? Answer: macroglossia, retrognathia, large neck circumference, hypertrophied tonsils or adenoids, and redundant pharyngeal tissue. Nerves for regional anesthesia. Question: what nerves are blocked in an intercostal nerve block? Answer: the ventral rami of the thoracic spinal nerves T1 to T11. Question: where is the safest place to perform an intercostal nerve block? Answer: at the angle of the rib, posteriorly. Question: what nerves are blocked in a paravertebral block? Answer: the dorsal and ventral rami of the spinal nerves as well as the sympathetic chain. Question: what is the landmark for a thoracic paravertebral block? Answer: the transverse process of the vertebra. The needle is advanced about 1 cm into the paravertebral space after contacting the superior aspect of the transverse process. Question: what nerves are blocked in an erector spine block? Answer: the block spreads craniocaudally to block the ventral and dorsal rami of multiple thoracic spinal nerves, providing analgesia for thoracic and abdominal procedures. Imaging anatomy. Question: on a chest radiograph, what does the right heart border represent? Answer: the right atrium. Question: on a chest radiograph, what does the left heart border represent? Answer: the left ventricle. Question: on a lateral chest radiograph, what does the retrosternal clear space represent? Answer: the right ventricle. Question: what is the aortopulmonary window? Answer: a radiological space between the aortic arch and the left pulmonary artery. Loss of clarity in this region can indicate lymphadenopathy. Question: where is the right hemidiaphragm usually located compared to the left on a chest radiograph? Answer: the right hemidiaphragm is usually about 2 cm higher than the left due to the underlying liver. Miscellaneous and integrated concepts. Question: what is the physiological dead space? Answer: it is the volume of inspired air that does not participate in gas exchange, including anatomical dead space and alveolar dead space. Question: what is the anatomical dead space? Answer: the volume of the conducting airways from the nose or mouth down to the terminal bronchioles, approximately 150 milliliters in an average adult. Question: how do you estimate anatomical dead space in milliliters? Answer: roughly 1 milliliter per pound of ideal body weight. Question: what is the pathophysiological basis of a tension pneumothorax? Answer: a one-way valve leak allows air into the pleural space but not out, increasing pressure, collapsing the lung, shifting the mediastinum, and compromising cardiovascular function. Question: why does a patient with a diaphragmatic hernia have respiratory distress? Answer: abdominal contents herniate into the thoracic cavity, compressing the lung and impairing diaphragmatic function. Question: what is the anatomical reason for pulsus paradoxus in cardiac tamponade? Answer: increased pericardial pressure compresses the heart, impeding ventricular filling and causing significant drops in systolic blood pressure during inspiration. Question: what is the mechanism of platypnea orthodeoxia? Answer: it is a syndrome of dyspnea and deoxygenation when upright, often due to anatomical shunts such as atrial septal defect or patent foramen ovale. Question: what is the anatomical basis for a Pancoast tumor? Answer: it is a lung cancer located in the apex of the lung that can invade the brachial plexus, stellate ganglion, and ribs. Question: what is Horner's syndrome and what are its signs? Answer: it is caused by interruption of the sympathetic pathway to the head and neck, leading to ptosis, meiosis, and anhidrosis on the affected side. Question: what is the blood-gas barrier? Answer: the very thin membrane between the alveolus and the pulmonary capillary where gas exchange occurs. Question: what is the clinical significance of the phrenic nerve's course? Answer: it runs anterior to the lung root and can be injured during cardiac surgery or be compressed by tumors. Question: why is the apex of the lung more susceptible to pneumothorax? Answer: the alveoli at the apex are subject to a greater transmural pressure gradient and are more distended, making them prone to rupture. Question: what is the clinical relevance of the bare area of the heart? Answer: this area is not covered by pleura and allows for procedures such as pericardiocentesis without entering the pleural space. Question: what is the anatomy of the thoracic duct and why is it relevant? Answer: it drains most of the body's lymph into the venous system at the junction of the left subclavian and internal jugular veins and can be injured during left-sided thoracic surgeries. Question: how does the anatomy of the airway influence the choice between endotracheal intubation and a supraglottic airway device? Answer: Endotracheal intubation bypasses the upper airway, providing protection from aspiration and allowing for high-pressure ventilation, while supraglottic airway devices sit above the glottis and are suitable for shorter procedures where airway protection is less critical. Thank you for joining us for this comprehensive question and answer session on respiratory anatomy for anesthesiology residents. Stay tuned for future episodes where we continue to explore the essentials of clinical anatomy. It's the Everything Surgery Podcast. Dissect the extraordinary.